Hello, good morning. I'm Ashok Rokade, consultant rhinologist and anterior-skull-based surgeon from Winchester and the University Hospital Southampton, UK. I welcome colleagues from around the world on behalf of organizing team to this inaugural Winter Global Rhinology Endoscopic Sinus and Anterior-Skull-based Surgery Webathon. Global Rhinology Network is a registered non-profit organization with a mission to foster surgical education in rhinology and skull-based surgery. We have successfully hosted annual multi-center live surgical webcast, The Lioness, since 2014 in collaboration with Lion Foundation. Thousands of surgeons from all corners of the world have benefited from it. More than 2,000 surgeons from 110 countries have registered for GRACE 2020. We will have hugely informative and engaging sessions presented by eminent rhinologists and skull-based surgeons from around the world. GRACE 2020 is hosted at the Global Telemedicine Studio of Professor Wilco Groneman in Utrecht in Netherlands. It is supported by Medtronic and Karl Storz. Thank you.
Imagine, what if you could do even more to bring relief to your chronic rhinosinusitis patients with technology customized to your unique clinical and facility needs? Introducing Stealth Station Flex ENT Navigation System, a customizable system from Medtronic ENT, a market leader in image-guided surgery technology, featuring 6 hardware configurations, an optional portable card, 2 different electromagnetic emitter options, with flexibility in hardware design and optional software functionality. Get everything you need and nothing you don't with Stealth Station Flex ENT. Let's flex forward. Contact your Medtronic representative to customize a navigation solution that's right for you.
I think, Ashok, if you're happy, we'll maybe move on for the sake of time to the second presentation.
You happy with that, Ashok?
I think you're on mute, Ashok, at the moment.
I'm happy to move. Louise, if you're happy for me to move
Lovely,
on.
thank you.
Okay, all right. Just let me know if I'm sharing my screen. Is my screen being shared? No. Let me do that. Let's do that now. Right, there we go.
That's it, lovely.
Okay.
Okay, I'm going to spend only 15 minutes really on this. You could spend a lot of time talking about the IFAC classification. But really, why did we come out, or why did the authors of this come out with a new classification? So this was a group of people and surgeons from all over the world that came together, put their minds together, all the great minds. Alki speaking after me. Claudia Cajekas was one of our fellows who's now a consultant in Chile. And I have to thank Claudia because I'm using some of his slides. He's kindly allowed me to use some of his slides, and he's got some brilliant slides, which I want to refer to. So really, it was to simplify the classifications that we all use terminology that is easily relatable. And we know it's easily relatable because we went on to publish a paper on this to look at the international assessment and intra-rate reliability, and it was very good. That was done by Phil Chen. So in the simplest way of talking about frontal sinus cells, as Tim alluded to again, it's about what do they do to the pathway. Ultimately, when I'm asking the residents and trainees to work out the frontal sinus drainage pathway, what I'm saying to them is, where can you put your probe or your curette that allows it to pass freely into a space? And so the way you work that out is by looking at the cellular architecture in that frontal recess. So think about the cells in that area. In the simplest way, are they anterior cells, or are they posterior cells, or are they medial cells? Okay, so anterior cells, if you think about a cell that sits anteriorly, that's things like the agonase cell and cells related to the agonase. If you have a cell anteriorly, it will push your drainage pathway posteriorly. Posterior cells tend to push the drainage pathway anteriorly, and that will be cells related to the bulla. And then medial cells, such as septal cells, almost always push your drainage pathway laterally because they're sitting in the midline. Okay, so we'll show you that with some examples. So anterior cells push your pathway posteriorly, posterior cells anteriorly, medially, laterally. Okay, so here we have a schematic really of a parasitial view of the frontal sinus. And that's the frontal beak area. And we're going to put an agonase cell in here. So here's a simple agonase cell, which is the simplest configuration you can have in the frontal recess. So this is an anteriorly based cell. And you can see that here using the image guidance of the position the anterior base cell sits. If you look at this picture, you'll see that any drainage is going to go posterior to this cell. That's very simple. You know that. But it's not always as simple as it. It's not just one anterior cell. You could have a cell above that anterior cell. That's fair enough. That may just be in the old terminology a Kuhn type 1 cell. It could be a Kuhn type 2. There may be 2 superaga cells. But these cells just sit above the agonase cell and they still just push your drainage pathway posteriorly. They may push it more posteriorly than before, but it's still just posteriorly. They don't, if you see that, they don't extend into this hashed line area, which is the frontal sinus. They sit below that frontal ostium. So these are just superaga cells. Now, what do they look like here? You can see them you can see them there as a simple superaga cell above the agonase cell. But what if your cell extends into the frontal sinus? Then what? Well, these are still all anteriorly based cells. You don't need to call them anything else. They just become superaga cells, but because it's now going beyond the frontal ostium, we call it a superaga frontal cell. That's it. You don't need to bother whether it's a T3 or T4. It's just a superaga frontal cell. What does it do to your drainage pathway? It still pushes it posteriorly. Okay, so there's your drainage pathway going posteriorly. So here's a schematic I put together. So you can see here, you've got an agonase cell, you've got a superaga frontal cell, and your drainage pathway just slides in behind that at the back. All right. Some of these cells, some of these supraagafrontal cells, they're quite high, and you may not be able to remove all of the cap of this cell through a standard frontal sinus drainage procedure. You might need to do an extended procedure to remove them. Or you'd be able to remove the bottom part, but not the top part of it. What about posteriorly based cells? So here we have the skull base, posteriorly, or the posterior wall of the frontal sinus, and you have the bulla ethmoidalis. So here's a bulla. There's a suprabulla cell. Now, we all knew these, and in days gone by, there were different names to it, bulla frontalis cells, etc. But this is just a simple bulla, suprabulla cell. Now, there's a frontal ostium. The bulla cells push your drainage pathway anteriorly. So you might find that they're cramped between a frontal cell and a bulla cell, but you should be able to negotiate your pathway between the two. So what does that look like on some images here? So here you have a bulla ethmoidalis, and then you have a suprabulla cell. That cell does not extend to the frontal sinus, but you can see that there's another cell just anterior to it, which is related to the frontal beak area, so that's an anterior cell. So what about this? So here you have a large suprabulla cell. Now this cell is extending through the frontal ostium. So exactly like the supraaga cells, these are called suprabulla frontal cells because they just push up into the frontal sinus. But as before, if you want to access this frontal sinus, you will need to fracture this cell posteriorly. So you need to push and break this backwards. It's very difficult to flick this forward. You just need to be aware that you can push them backwards, fracture them, and open up that drainage pathway. And you might need to do an extended procedure to get the cap of the cell out if they're very extensive. So the drainage pathway is pushed anteriorly. Here's an example of a patient. When you look at this, first of all, this first coronal, this can be quite confusing. You look at this and you think, what on earth is going on here? They've got these two cells high up against the skull base. But if you think about it, this cell is not in contact with the frontal process. It cannot be an anterior cell. All right, it's up against the skull base at the back. The clue here is really looking at the axials. And people don't look at axial imaging enough, but it is the planning image for your frontal sinus dissection, because it is the image in the anatomical position of how you're going to dissect your patient. So this is what you're doing when you dissect. You're putting your frontal sinus probe anteriorly and you're pushing this back. And it shows you beautifully on the parasagittal, this large bulla and this extension of this bulla coming forward, this suprabulla cell, which has cramped this frontal sinus drainage pathway anteriorly. So the two differences, the main things to take away is if you have a supraaga frontal cell, you're pushing your pathway posteriorly. If you have a suprabulla frontal cell, because it's coming from the skull base and the bulla, you're pushing that pathway anteriorly. You may need to negotiate other cells in between, but that's the key between those two areas. So here are all the cells stuffed into one sinus. I love this picture of Claudia's, and it shows you've got the bulla ethmoidalis, suprabulla cells, suprabulla frontal, supraaga frontal cells, supraaga cell, and aganase. But that is it. That's all you need to. That's all you need to understand and learn about. That is it. The neatly based cells, the septal cells, they're not difficult to work out because they're within the intersinus septum and they push your drainage pathway out laterally. They don't do a lot more than that. What they can do is make your life a little bit easier because they may pneumatize and open up into that frontal sinus drainage pathway on that side. So often they can end up being a little bit more wider on that side. So here we go. That's a drainage pathway, and that's the lateral aspect of the drainage pathway. Probably the most, which I know there's a lot of consternation about this, is the supraorbital ethmoid. Now, I wouldn't get too excited or too worked about supraorbital ethmoid. Safe to say that if you see a supraorbital ethmoid, you need to think about one thing. And the main thing is you will often have a long lateral lamella of the cribriform plate, and the anterior ethmoidal artery is likely to lie in a mesentery. And I'll show you that. So supraorbital ethmoids pneumatize the orbital plate of the frontal bone. So normally your orbital plate of frontal bone and your frontal sinus floor are together. But if you have a supraorbital ethmoid, those areas get pneumatized. I'll show you that. The opening is posterior to the frontal recess or posterolateral to the frontal recess. And the anterior arteries often are the mesentery. So here we go. Here's the frontal sinus area. Here's your frontal beak area. Important to understand. It's a transition from the frontal sinus into the frontal recess. So here you've lost your frontal beak. So you've got, I've put a hashed line in. Now you're actually in the frontal recess. This is not the frontal sinus. This is the supraorbital ethmoid area, okay? Because you've pushed the orbit away from the skull base. You've pneumatized the orbital plate of the frontal bone. And you can see here in this axial how it pneumatizes all the way around the back. And what you'll notice here is look at the anterior artery. It's about 17 times more likely to lie in a mesentery if you have a supraorbital ethmoid. So that's probably the most important thing about it, is that you need to be aware of your arteries. So in summary, this is a really easy classification to remember. It's easy to work with, easy to remember, and it's based around where your drainage pathways are not about the number of cells that you've got going on, which can be quite confusing. So it just describes the cells as a relation anterior and posterior, which essentially influences your drainage pathway. That's it.
That was great. Thank you very much for another excellent talk. And I think as you've summarised there, it's just the classification system, it really highlights what can be seen as a very complex anatomical area and simplifies it. And it's a reproducible classification system that makes the surgery more simple. We just have a poll there. If the delegates could possibly fill that out, please. It's on the frontal sinus anatomy and asking which classification do you use to assess the anatomy. We just have a few questions, if that's all right.
Yes, go for it.
Do you have a pro forma that when you're assessing your CT scans pre-operatively for the frontal sinus, will you document it, or is it just form part of your normal routine assessment of the scan?
So that's really good, Louise. I see Alki, Professor Alki's just joined us as well, and he will attest to this. So what I try and get the registrars, and what I do myself as well, and I do it all the time, is I will draw out that drainage pathway. For my mind, I'll draw it out and I'll stick it on the stack And so it's there. And when I'm operating, I can refer to it, and I get the trainees to do it as well. I did it when I was a fellow, and I still do it now. I find it very useful in my mind, because when I think I've worked it out, I kind of forget. And so if I've drawn it out and I know where it is, I know I only need to really know what the axial and the parasagittal are doing. The coronal I can see, but it's the axial and parasagittal. So I do have a plan, and I draw it out, and I get them to draw it out as well.
I think that's very good advice. And do you use a surgical navigation system for your endoscopic frontal sinus work?
No, I don't use navigation for the front side. I use them for the drill outs, and if there's something a bit tricky. But generally speaking, no, I don't use it for standard frontal sinus stuff.
That's great. And just lastly, do you find that you change your instruments at all based on your pre-op plan, based on the classification system? So would it make you more likely to use, for example, a RAD90 or a specific type of angled spur?
Yes. Yes. So with a straightforward frontal sinus dissection, I would always, and I would suggest all do the same, is that you have some wormhole malleable instruments. They are by way and a margin the most useful instruments that I use in the frontal recess, because the probe is beautiful. It's much longer than a standard frontal sinus seeker, and you can bend it in any way. So if you know you've got a really acute angle, you can bend that probe because it's malleable, and you don't go bashing into the skull base. So that would be my go-to instrument, is those malleable frontal sinus seekers. And then yes, a RAD60 blade, you might need that, and that's often really useful. I don't tend to use a drill unless I'm going to make a big hole, but yeah, those instruments I'd say absolutely influence what I do, totally.
Fantastic. That's great. Well, thank you very much. That was 2 excellent talks, and we're very privileged to have heard them today. Thank you.
Thanks very much, Louise. Great to see Alki on. I'm going to stay and listen to his talk.
The head and neck surgeries you perform are vital. Your patients place their trust in you. You help them continue to speak and smile, eat and drink, hear and comfort. You're committed to helping them continue to live fully, to feel deeply, and to enjoy the quality of life they've come to expect. That means being confident that you're protecting and preserving your patient's head and neck nerve function during procedures. Introducing NIM-Vital, the next generation of nerve monitoring technology. NIM-Vital provides advanced nerve monitoring that helps you reduce the risk of nerve damage during head and neck procedures. Detailed intraoperative nerve condition information helps inspire your surgical strategy. An intuitive user interface with a wire-free patient interface allows for easy setup and enhanced visualization from the surgical field. Real-time notifications of nerve conditions, visually and audibly. Green, yellow, and red status bars provide visual information, and their associated tones provide audible cues, making monitoring function easier than ever. NIM Nerve Trend EMG reporting enables nerve condition tracking throughout a procedure, even when using intermittent nerve monitoring. And when paired with a NIM continuous monitoring electrode, you have continuous nerve monitoring informing your surgical strategy. NIM-Vital pushes the boundaries of monitoring nerve function in various procedures in head and neck surgery, with real-time information available during surgery, giving you confidence in nerve function. Because protecting patients' nerves and senses is more than vital. NIM-Vital.
Imagine, what if you could do even more to bring relief to your chronic rhinosinusitis patients with technology customized to your unique clinical and facility needs? Introducing Stealth Station Flex ENT Navigation System, a customizable system from Medtronic ENT, a market leader in image-guided surgery technology. Featuring 6 hardware configurations, an optional portable card, 2 different electromagnetic emitter options. With flexibility in hardware design and optional software functionality, get everything you need and nothing you don't with Stealth Station Flex ENT. Let's flex forward. Contact your Medtronic representative to customize a navigation solution that's right for you.